can give you a false positive of D-dimer. So please, don't do the same mistakes as many ER physicians or practitioners that a cancer patient is walking in and they do a D-dimer. Of course, it's going to be positive. And it's going to be in the 5,000. Okay? Pregnant patient, that's the physiological hypercoagulability state. Of course, it's going to be positive. If you're thinking about any thromboembolic event, just do the test. Okay? Any patient that has any type of hypercoagulability, or again, if you're bleeding, how do you think your coagulation cascade is reacting? All right? Any major sepsis, patient with a stroke, so already patients with autoimmune conditions, patients with hypercoagulability, patients with cancer, patients even that recently had a surgery, what would you do with D-dimer? It's going to be positive.
They typically do it anyway, though.
I know, but then what happened? Then it's high, and you have to do the rest.
Professor, D-dimer stands for one. D-dimer.
Okay. D-dimer.
So we also, we used to say D-dimer, D-dimer.
D-dimer is no more than fibrin degradation by products. It is not letters for a significant. Okay? Now, ventilation perfusion scan. Ventilation perfusion scan, basically, you will give a patient a radioactive gas for them to inhale. Okay? Less reliable when the patients are on a ventilator, right? But if the patient is able to breathe properly, spontaneously, without a ventilator, what happens is that you give a gas to the patient and they do, hopefully I have one, I'll look during the break. Imagine that I inhale the gas, okay, and the first phase will be the ventilation gas. What is ventilation for you?
Air coming in.
It's just the exchange of gas. It's breathing in and out at a normal breath rate, respiratory rate, okay? So that is ventilation. So the ventilation portion only will tell you if the patient has any tissue problem, okay? For example, if I inhale normally and I have air trapping or the radioactive gas trapping to exhalation, what would you think that the patient has? Emphysema, right? Chronic bronchitis, or any asthmatic patient that the expiratory phase is delayed. That's all ventilation is telling you. In addition to that, ventilation is affected when you have a parenchymal problem. That inspiration instead of expiration is affected, for example, if the patient has pneumonias or effusions, etc. Okay? So the first phase of VQ scan tells you the ventilation portion, so ventilation. And if I have a VQ on the real patients, I will show you how it is. Basically, this is the patient, look, and the scan is basically scanning the patient around while the patient is inhaling gas, right? And you see the lungs through the front, and then in this angle, and then more lateral, and then like this oblique, and then posterior, and then like this, and then more oblique, and then frontal again. As the phases passes, which are 3 phases of ventilation, you have to see in the initial second phase, the gas completely disappear. Right? When you see in inspiratory phase, you see a defect, the patient has a parenchymal problem. Tumor, cancer, pneumonias, effusions, etc. If in the second phase down, the gas is still there, and there's no defect in the first phase, you have a problem in expiration, so most likely air trapping, such as emphysemas or chronic bronchitis patients or asthmatic patients, etc. Do you understand? Then it comes the perfusion. Ventilation phase already passed, and then I do the perfusion, the gas traveling through the pulmonary artery and the branches. And what you're looking at is the defect, okay? And if this is the phase cases of perfusion, you're looking at the entire border of the lung to see if any clot produced any defect in perfusion. Do you understand? So imagine that I have something like this. I have a defect in perfusion, right? And again, you need to know your anatomy, because if you have a lung, which you know that the right lung is completely homogeneous, right? Because you have 3 lobes, there's nothing else there. But the left lung, you have the heart here in between, right? So what the left lung does is this, to allow the heart to be there in between. So this is a normal anatomy defect that you would see. But if you see it up here, or if you see it here, it's not normal. Do you understand? Now, there's reports that it says intermediate or high probability. The intermediate probability, we always try to match with the CT. Of course, in this case, if you have to do a CT angiogram, there's no problem because you go straight and you rule out the PE. But if the patient cannot have contrast because it's allergic to iodine, or the patient has, for example, bilirubin creatinine elevated, you cannot do a CT angiogram, and we do a CT chest plain. What is the importance for that? Because if you do now a CT chest plain, and you have a defect in the VQ scan here, which is not the normal anatomy, and I now do a CT scan of the chest and I see a tumor there, that's a match defect. Do you understand what I'm saying? It's not a pulmonary embolism because the match defect of the VQ coincides with the match defect in the CT because the tumor is present at the same location. Do you understand? But if I now do a CT chest and I see it completely normal and I still see that defect, the patient must be on anticoagulant. And if you repeat a VQ scan in less than a week, you would see that from intermediate probability passed to low probability. That's another indication that the patient had a PE to begin with. Do you understand? Okay. So the VQ scan in medicine is interpreted as, first, if you have ventilation is affected, but perfusion is normal, you have a shunting. You have a shunt. That means low probability. If you have ventilation affected, could be COPD, could be asthma, could be pneumonia, could be pleural effusion, could be anything in the lung, but not in the vessels. Do you understand? Okay? On the contrary, if ventilation is normal, but perfusion is affected, you have dead space. And dead space is a PE. Do you understand? Okay, so this is low probability, and dead space is high probability. Now, intermediate probability is a VQ scan that has a defect in perfusion, but when you match it with the CT scan, the patient has a lesion at that location.
That would be
Intermediate probability.
but it's not like dead space, we always are gonna have dead space.
That's a different dead space. She's referring to what is dead space in pulmonary medicine. Dead space can also mean an area of the lung that gas exchange is not produced. The only anatomic space where gas exchange is produced is at the level of the alveoli. Bronchi, bronchioles, pulmonary artery, pulmonary parenchyma, trachea, mouth, nose is a dead space. Ventilators, the tubes, your trachea, your pulmonary artery, and branches are dead space. That's another definition. And yes, of course, we will always have dead space, but this dead space refers to the patient has a deficit in perfusion due to a clot, but the ventilation, inspiration, and expiration is not effective. Okay? And that's the entire explanation. So why do we do sometimes a lot of BQs? Is because it's low cost. And you have a low level of suspiciousness. But if you really, really believe that that patient has a PE, don't do BQ first. You're wasting your time. The patient can die. Okay? And basically this is just a picture of the pulmonary angiography, which is your CT spiral, CT angiograms, the same thing, right? That is the gold standard examination for PE. Okay? So basically what you're looking at is, yes, the cutoff defect, because I have more different views that I can open in that CT. Here you see it brighter when I open the angiography portion, but when I open the vascular view, which was the one that you saw, basically what you see is a gray color or darker color, basically a defect in color of the iodine, okay? And we've talked about the treatment already. So you can take a break and come back for another case.